Blijft alles rood? Ja.
The man who takes care in standardization in practical level.
Hi, my name is Johan. Pleased to meet you. Yeah,
I say that you take care of the standardization now.
very important. We like to come to you if possible because we are now working on trying to standardize and get a better decision tree on adrenal diseases. And we see there that ICD-10 and SNOMED is incomplete. And we're expanding it. And we like to share it with you. So, so by the time later this month, early August, I will come back to you. And how is your first name? Juhu? Juha.
Wat zeg je?
Ja, oké, thank you.
Timing hier. Normaal heb ik het gewoon.
inspection. You need to be careful when you talk about Spanish inspection. 500 years ago we had Spanish inspection as well, and that was not very peaceful. Especially this area was 1600 so much in 80 years war with Spain. So just imagine, not with Belgium, not with France, not with Germany, no, with Spain. Yeah. Just imagine. Make life complex.
Ja, dat ging vragen.
No, or my work, I'm based in Zwolle, which is in the province, but I am working overall the Netherlands. Anywhere in the Netherlands, I will be working. So I might come back to you and see if we can get a Spanish solution for our app, because I will talk about apps. I think we should try to get a Spanish edition of it, because we have endocrinology professors in Barcelona who are very much in favor. You are an organization that have things organized, and we could easily, by means of a little translation and a little understanding, maybe one meeting, have you an app available in Spanish. An app for, and that's important, for adrenal patients only. So that is because these patients can be in danger, then every minute counts. So when
Zullen wij beginnen? Want ik weet niet wanneer jij hem...
when this
Ja. Ja.
when this app
Ik
is
heb hem niet
available,
nodig hoor, maar de
also
eerste
in
spreken
Spain,
we. Ja.
Spanish people can use it, but Dutch people can also use it. Yeah.
Oké. Ja.
Okay.
Doet hij het al?
Okay. Yes. Very good. And we make it
Okay, welcome
already.
everybody.
Look here at the bottom.
If I could have your attention, please. Welcome to the session about building bridges between professional and patient data, the merging of the PHR and the EHR in healthcare. First of all, I would like to start off with some boring announcement. Could you please remind me to mute your phone? Actually, you can't hear me? Is it better? Should I use this? Yeah? Is it? Oh my god. Sorry. Well, anyway, welcome. Yeah, I would like to ask you to mute your phone just in case we don't want any disturbance. The only reason to use a phone, of course, is to contribute or follow the eHealth Twitter. And at the end of the session, you will be asked to reward the session on the mobile app from the eHealth week. So I'll be asking you to do that at the end of the session. Anyway, my name is Inky Teus. I'm the CEO of a beautiful company called Carify, and we've actually been making a PHR ourselves for about over 10 years now, and we're one of the biggest providers in e-mental health care in the Netherlands. But today's session is about 3 beautiful examples that have been accomplished over Europe about PHRs and in the different ways they've been accomplished. We have 2 PHR examples that are more like on a big scale, like from a whole country or a whole region. And there is one example of a PHR that's been accomplished by focusing on a specific patient group. And I think it would be very interesting to see what the benefits are from the one approach and what the benefits are from the other approach. So what benefits do patients really gain from it? What benefits do professionals see? What obstacles are there for professionals to exclude their data? Do they find it okay, or is there a lot of obstacles to overcome there? Well, those are my brief thoughts about this session. Luckily, all three of my presenters have told me that they would like an interactive session, so if you have any questions or discussion points during their presentations, feel free to ask. So I'll be walking around with the microphone, so you can ask anything during the sessions or after the sessions. I would like to start off with my first presentation. Mr. Timapukka Virtanen from Finland. I don't know if I pronounce it correctly, but anyway, he's a senior advisor from the Ministry of Social Affairs and Health in Finland. And I would like to hand the stage to you.
Thank you. Is my microphone working? I assume it sounds like that. My name is Teemu-Pekka Virtanen, as pronounced it that way. And I used to be head of these national e-health projects, but since the beginning of this year, I have now concentrated more on these personal health records, or those new services that we are going to provide to citizens instead of this healthcare system. We finalized a new strategy about this area, information management, 2 years ago, and this is just a picture from that strategy. The main points in this strategy are that the citizen must be emphasized to do more, take care of himself more than currently. Another thing is that you should really get all this information in use instead of storing information. We should use the information. We are not starting from scratch. I mean, these national systems we have built during several decades have now reached such a point that we have a very large mass of information there. Almost all of our prescriptions are electronically. Almost all people have now information, patient records stored in the National Archive. We have 100,000 users of this system, citizens using this personal side of this system. So we actually have a huge mass information already there. We have had some attempts to build this kind of PHR system before, but they are not managed very well because they have not reached such an amount of users that they have begun flying. Now we assume that all this background work we have actually made for these systems before give us that advantage that we really can proceed this and achieve a potential big enough. So our strategy main point of strategy is to emphasize give citizens tools to manage their own wellness. We put together social and healthcare, so this is not only healthcare, this is wellness in general, including also many things that are part of social care. And then the other points of the strategy is, of course, that we must put this information also usable for the professionals. Even I believe that giving tools to citizens makes an improvement itself, because if the people are interested in their wellness, they also take care of themselves better. But another essential point is that the information must be used to the professionals. If we have isolated systems that no information goes to the professionals, then the usefulness is not so big than it should be. What we are building here, we are building tools for citizens. We are building a PHR system that is provided to all citizens for free to use, store in their own wellness information there, and then we give them some tools that how they can manage this information, how they can get advantage of this information, and that way we assume to get people interested and take care of themselves. The scale of this social and healthcare area is quite large. We start from very simple services, more like giving information. Giving trustful information is important. but actually it's maybe not anymore something real exciting area. We already have those systems how to share information with people. On the other hand, there are many very advantaged services, healthcare in tertiary care hospitals that is not possible to make really electronic. But in the middle of this picture, we have an area that we believe that is suitable to build new kind of services and achieve the best possible results for this area. And actually, this is also the area where this PHR is the main place to store this information. This kanta here means actually the place where professionals store the information. I assume that these slides are available afterwards, so no need to take pictures of this. And for that purpose, we are building some new elements in our system. I already mentioned this PHR storage, what we are putting in the bottom, but we are also increasing this service we provide for citizens. Built there actually two new type of services that people can use to store the information. One point, I think main point in this session is how to share this information. What is difference between this kanta and oma kanta, the EHR and PHR, or this official information and private information? It's actually quite crucial difference, and it makes it very important to manage how information is transferred from one place to another. We have very strict legislation how we should manage these official patient records. There are rules how long time it must be stored. There are rules how it must be used or can it be used, and so on. On the other hand, when we have this private side, there is actually no rules. It is more or less people store their information and then they use it. There is no legislation saying that how long it must be stored, or there is no legislation saying that it must be correct. I can store any information I just put there. Nobody takes care if it is correct or not. But what happens when I give this information to a doctor? Actually, it becomes patient record. After that, doctor has seen what I have shown, and when doctor makes decision, maybe makes a wrong decision, then it is looked what information the doctor has. It is not possible that I can change my information after giving it to doctor, because otherwise it's not possible to afterwards find out what information the doctor has when the decision is made. So actually giving information to a doctor makes this piece of information as a part of patient records. It must be stored according to the rules after that. So that makes very important to manage the process how to give this information to a professional, because all the rules change in that point, and it must be done in very, very strict, manageable way. So we have these two information storages, and in the bottom we have those systems that use those. We have these professional systems in hospital and healthcare centers that are communicating mainly only with this official side of the storage, because it represents the official information. Doctors use, or healthcare professional use, social care professional use, and this is under all those rules. Then we have this citizen portal that is actually what we offer to citizens. It is actually currently it is a way how citizens can see those official documents. So they have access to not all, but very big part of those documents that are stored by the officials. But they of course can't change anything, but they can see it. And this is also happens in the future but they also can this way manage those documents they have stored themselves to this private side. Then we will have some set of new e-services that are some sort of services that are offered by healthcare organizations, those who gives these health services. They can extend their services to electronical side, and for that purpose they can build these systems. And those systems can actually access both official side and this private side, depending on the services itself. If it is service that is given by a professional using professional devices, then maybe it can store information directly to the official side. If it is more not so professional, maybe its devices are not certified, maybe there is actually no connection between a doctor and so on, then information is stored to the private side. And in the fourth way is that we are going to give an access to different kind of apps to this system. So actually, instead of getting something from a healthcare provider, I can go to App Store and download something to my mobile phone, shop some personal devices and use them, and this information is stored to this private side. So we have actually here 4 types of information sources or 4 types of information users. We have 2 storages, and we have a well-mannered designed way how to transfer information between these storages. It also can do another way, so that I can actually transfer official documents or information from official documents to this private side to be able to do some own management to this information later. Then again, it's not official information anymore, it's my own information that I can manage. This Omakanta PHR is something what we are actually already building. Here are some details about that. Point here is that we try to keep the information model as flexible as possible, because we try to keep it open to all those startup companies to make it possible that they can store information. We can't have a 2 years long certification process how to validate information model that can be stored there. It must be much more flexible. But we won't keep it open, and that means that we don't like to have any silos or some closed areas for certain companies. Information itself is open, but how it is stored can be flexible. Then we have these new services. We have currently going on a project that build new type of electronic services provided by public healthcare. I assume that there will be same kind of services later provided by private healthcare, but we are now in this point that the first project is building this for public healthcare. And then this gateway that I mentioned, it's still under some sort of negotiation. Who is going to take care of this? Because it's our core business is wellness. Keep people in good shape in every way. Our main business is not promote business or build these tools how to make business in this area. We only give an opportunity to that, but we are not really running this kind of system. Where we are now, this PHR is under construction, but it's actually so far already that some companies has been able to test their systems against this. But basically this is usable after a year, and it's going to be open to public usage after a year and after holiday season, so a year and a half. In the same time, these new services are going to start it first in those cities that are now part of this building projects, and then in the end of 17, it's going to spread to all of the country. And then we still have new projects coming. This innovation hub is still looking how to build it. I can say that the budget of all this is currently something like 20 million euros. It covers now this PHR system and the first set of these new services we are building. Okay, that was my presentation. Not so much.
Okay. Are there any questions? Anybody? Yes?
Hi, there we go. I was specifically curious about what, we tend to talk about capturing information from patients in a very generic sense, and in reality, the array of data that you can capture, structured information that you can capture from a patient is quite large. Things as basic as, how much did you weigh today, or what was your blood pressure, to more complicated structured data like survey information and information that you can calculate scores based off of. Do you have a particular focus with your PHR implementation in terms of which areas you're looking at initially, or are you casting a fairly wide net in terms of what information you're looking to capture in your first iteration?
Well, actually both. I mean, we have in mind some set of core services, core structures we are going to build there, especially what are needed by these first projects, and there are a number of well-known or well-defined type of information. But in the same time, we want to keep this system as flexible as possible. So it should be something that if a company has their own, something that is not defined yet, it should be possible to store, but in the same way the company must publish the structure in such a way that if another company wants to use that information, it's possible. So we don't want to have any locked information there, but it's possible to store something that is not well defined yet.
Actually, what feedback do professionals give? How do they feel about exchanging all their information?
Well, this system, actually, especially these services, they have been used in one city already. Some sort of pre-testing these ideas, and I think it is mixed
feelings.
Mixed feelings. There are doctors who think this is a good way, but there are also I have get some feedback that from a doctor that I don't believe anything that I don't measure myself. So it's totally useless to ask anything from the patient because he lies always. So okay. I must measure everything myself. This is also this kind of opinions I have got.
Okay, thank you very much. Are there any more questions? Okay, we have time for one more. Oh, sorry.
Is there any duplication between the two systems? You thought that if the professional is using part of the information from the private system, it cannot be deleted anymore. Is it physically declared undeletable in the private system, or is it somewhere copied in the professional system? And well, yeah, that's my question.
There's still some discussion and different opinions. Personally, I have no other choice than copy the information, because the rules, how it should be handled, is so difficult. I don't want to build PHR system the same rules that are professional system. It's actually easier to copy, but it's not really decided yet. So I don't say just for sure, but this my opinion is that it must be copied.
Okay, thank you very much. I'm afraid we're going to have to move on to our second speaker. This is Enrique Lopez from the beautiful area of Catalonia in Spain. He works as a project manager for the TIC Salud organization, and they've actually realized for the whole region of Catalonia a PHR. So let's hear about the use of your PHR. Thank you.
Thank you very much. So let's start. Okay. So good afternoon. Thank you for inviting me to participate in this session. Today I want to talk about 5 main points, or 5 points that. First of all, briefly, I will introduce TIC Salut Foundation and its roles in the Catalan system. Later, I will explain you the Catalan healthcare model, and then talk about the medical records, the Catalan medical records, and the personal health record that we have in Catalonia, that we already have in Catalonia. And to close my presentation, I want to talk about the future project that we will launch, I hope in the next few weeks, that is called mHealth Hub. So to start, TIC Salut Foundation is an agency of Catalan Ministry of Health that aims to promote and foster the use of new technologies in the health and social care sector. So the Catalan health system, right now in Catalonia, we have around 160 different healthcare providers for the public health sector, I mean, that have completely freedom to choose which information system they want to use. That means that right now we have more or less 60 different IT systems running nowadays. And in this scenario, the government has to guarantee the interoperability of among all of them. So in this context, the government has built what we call the HC3, that is Historia Clínica Compartida de Catalunya. It's in Catalan, that is the electronic medical record of Catalonia. This is a platform, it's a space where all the relevant health information about the Catalan system, Catalan citizens, is stored. And this is a great advantage for all the professionals of the public health sector, because they can check that information and have a holistic vision of their patients. In terms of figures, nowadays, almost 100% of the public healthcare providers are connected with this platform. That it's the same that say that more or less 665 centers are connected. The data is collected in this year. And the professionals the platform has 152 million of documents that the professional can look for. The aim is that soon we want to connect that platform with the information provided by social service and other areas related with the persons, with the patients. So this is our aim. This is what the professional has to exchange information about their patients, and from the citizens or patients' point of view, the government has developed that the LMS, that it's in Catalan is La Meva Salut, that we can translate by my health. That is a virtual space where the citizens can access to their medical information. They can access via website or tablet, or also by mobile phone. Here they can find the clinical reports, diagnosis, medication plans, vaccines, and all kind of information, personal information related with the healthcare. The evolution of the access to the platform is increased, progressive increase in that last years. Another important point of the La Meva Salut is that the Catalans can access to their private space in Absolute website. So until now, we have a platform in which the professional can exchange information about their patients. We have another channel, another platform that is La Mia Salud, in that the patients can access to the medical information, but we want to close the loop, and we in the few weeks we'll launch that what we call the mHealth Hub, that is basically is composed by the Absolute website and what we call the digital health platform. Mainly, the Absolute website is a showroom where we put apps related with the health and social care area that has passed an accreditation process. And the good thing is that the professional of both areas will be able to recommend the use of that application to their patients. And their patients, if they use that application and generate data, they will be able to share that information directly with their professionals. And at his turn, the professionals, if consider that information enough relevant, they will be able to copy directly from the medical records of that specific patient that generate that data through the digital health platform. So the main picture is that one. We have three main building blocks. The first one is the Absolute website, that is the showroom of the apps, the digital health platform, that is where all the information generated by the patients is stored, and also the accreditation process. So the process starts when the patients go to visit his or her professional, and as now the professional can prescribe a medication or pill or whatever, but also the professional will be able to access to their private space in the Absolute website, select one or more application, and recommend it use to the patient through the personal health record, the LMS that I explained before. As it turns, the patient will check that application and goes to the market, the actual marketplace, download the application, use that application, and the data goes directly to the digital health platform, in which both patients and professionals can check that information just in one screen, no matter which application or which application generates the data. And as I said, the professional will be able to select one or more data if they consider relevant and copy to the HC3. This is the platform in which all the main medical information is stored. So this is the main picture. In the next slide, I put some screenshots to show you that is a reality. It's not just a PowerPoint. That this is some screenshots. This is the homepage of the Absolute website. Here we will have all kind of applications related with both sectors. Also, if we go to one specific application, this look like what we can find in the current marketplace, but we introduce some modifications. Here we have a figure that becomes from the accreditation process that the application has to pass to be included in the Absolute website. And also we have here two different rows of stars, if depend the opinion of the professional or the other users that use that application. So I, as a doctor, can see the result of the process of accreditation process, but also the opinion of the other professionals or the patients, at the same as the patients. Here, the professionals go to their private space in Absolute, goes to the functionality to recommend an app, select one or more applications, introduce the cell phone, the number of the cell phone of the patient, and send the recommendation. Here, the patient receives a message reminding that he has a new recommendation. As it turns, the patient can see which app was being recommended, use it, and send the information to the digital health platform, and then he can see the data generated. In this case, the patient only see the data generated by just one application, but if he uses more than one, all the data appears in this screen. The same for the patient, the professionals. They can see all the information generated by just one patient. They can select it, can select and copy to the H3C3, and also the professionals are able to create graphics. The accreditation process, the third main building block that we have in mHealth app, it's a 6 steps process. First of all, the developer introduces some relevant information about the app. Then he's able to do a pre-assessment. If he considers that all is okay, can present the application to the Fundació TecSalut. We create an mHealth office that is in charge to evaluate all the applications. We classify the application in 3 different levels, depending on the complexity of the application. It's not the same one application that just gives a general recommendation and another that monitors the blood pressure, for example. And depends which level we apply one's criteria and others. We have a pool of experts in different areas that evaluate that application, and if the process is correct, we include the application in the website. This is what we will launch in the next weeks, but the future, our vision, is not only include the information that comes from application, but also include all information that generated by wearables or medical device from the patients in order to the professionals have more information to personalize the treatments. And that's it.
Thank you. Is there any questions? My microphone doesn't seem to work. Any of them? Okay, we have a question over here. Check the microphone. Oh, it works. Or is it just?
I guess. Yeah, so hi. My question is it actually mandatory to use the Absolute for the practitioner? So I guess it's voluntary for the patients, but do practitioners actually have to work with that?
Well, they will have the option to work with the Absolute. All the professionals in Catalonia from the public health sector will be able to go inside their personal space and recommend apps. But if they do or not, it's their choice.
I would just like to ask, have you got any data on which information is mostly used by professionals or patients? What exactly do they use mostly on the website?
Well, we'll launch the website in 2 weeks, and we will accept all kind of applications.
So yeah,
All that cover all the disease in the healthcare or social care fields. So we'll be able to include all kind of information, and then the professional they will check it.
okay. I saw some more questions over here.
Hi, thank you for interesting speak. I'm a technology advisor and I worked with a diabetes diary for 10 years now. And we have collected data from diabetes patients. One of the reasons our doctors haven't wanted the data from the patient is that they are afraid they will be responsible if something bad happens. So if the patient have low blood glucose in the middle of the night and fell ill and no one reacted and they die from this, then suddenly it's the doctor's responsibility because they got the data. Have you had any similar considerations in working with this?
Well, at the beginning, when the information will go to the digital health platform, and in theory, the doctors will only check it when the patients go to visit them. but in the future version, we thought about if we can put some kind of alarms if the professionals want to follow one specific patient and create alarms and so on. But until now, it's asynchronous.
Okay, we have. I'm just got the gentleman over there. Yeah. If you could just pass the microphone.
Could you explain a little bit what you did to involve patients in the design of the system, in the design of the screens, and how do you keep them in the process of evaluating what you do?
From the beginning that we start to think about this project and how they do looks like, we involve all kind of stakeholders, from the professionals, app developers, wearable developers, and also we involve the end users. In fact, the Fundación Salud has one board of experts, advisory experts, that is the members are patients. So we involve from the beginning. So during all the process, we ask them if they are comfortable with this platform, with the layout, and we receive, and also we receive feedback, and also we introduce some modifications to the comments.
Okay, I have time for one more last question. Anybody? Well, then it's your way.
Thank you. I saw on one of your slides the professional using a patient viewer.
Mm-hmm.
Does this mean that he has to go to another application to see the patient's data, or is it integrated in his own professional tool?
It's integrated. It's completely integrated.
Okay.
It's completely integrated. Mm-hmm.
Okay, thank you very much, Enrique. If you would like to just sit on, I would have asked Mr. Vitanen as well to sit on the stage for the questions that we can do afterwards. I would now like to ask Johan Beun. He's the coordinator of AdrenalineNet, a Dutch platform, or international so far as I've heard, on which professionals and patients suffering from adrenaline gland disorder can share knowledge and information and work together on their disease. This is actually a completely different approach of realizing in a PHR. It's like a PHR for a very specific group of patients. So it's interesting to see what successes we gain from that. So, Johan, up to you.
Thank you very much. Ladies and gentlemen, at the beginning I would like to address a few items. First of all, I am only a chief of empty boxes and not a medical doctor. That is very relevant if you put questions to me. But the other thing which is very relevant is that we are not against anything. We are not against a national system of an electronic health record. We are not against any regional system. We are not against anything. People should do what they please. For those who know me, I have been 5 years on the board of the Dutch Patients Organization and 10 years on the board of NICTIS. I've done my utmost best to get in the Netherlands an electronic health record. So far, we have not succeeded. That has nothing to do with my personal religion in this respect. But when we came to a specific group of people, we had different questions and different answers. If you look to our community where we're talking about, it is a small community, relatively small. But mainly it is all parties concerned, and it's get away with the silos. The endocrinology specialists were there, the endocrinology nurses were there, the patient organization was there, and the carers were there. Altogether we work for about 5, 6, 7,000 people in the Netherlands who have adrenal problems. And adrenal problems can be very curious, but also very problemful if you don't look after them. If you look after adrenal problem with your pills in time, if I may phrase this, then nothing happens. But if you don't care in worse or bad times, then you might die. So for us, the essence of getting things right and soon in the hand of the patient was far more different than in a general situation in the Netherlands. If you look to our environment, for those who do not live in the Netherlands, we have about 17 million people in our country. We have 90 hospitals, of which 8 academic hospitals, and that's very crucial. All those 8 academic hospitals are founding father of our work. We have a national organization for electronic healthcare standardization work called NICTIS. It has done a lot of good, but it has not come to a success yet. And we have no national standards for a rare disease like adrenal disease. We went into ICD-10 and to SNOMED and we asked all the documents and we had our specialists put on it, and unfortunately we had to see that the doctors were not able to code it in the right way. So when we asked statistics on a relatively big university hospital which had recently gone into a new hospital information system, and we asked how many people do you have with adrenal diseases, the answer was 0, while we have on record about 600 people going to that hospital. So semantic interoperability, ladies and gentlemen, is crucial. Don't go into medicine, don't go into electronic patient record, don't go into whatever you do if there is no semantics. Semantic interoperability is crucial. And in the Netherlands, we have a scattered landscape. We have with these 90 hospitals, too many hospital information systems. As a taxpayer, I'm very much disappointed. We should have had one system, or anyhow, one national system, because we are like Madurodam. We are a small country, 17 million people only, and we could have solved it when the millennium changed. But we failed. We just failed. And which is very crucial for you to know, is that at the moment of an Edison crisis, it's crucial that these Edisonians or adrenal patients get a shot of hydrocortisone. If they get a shot of hydrocortisone, put them aside in the emergency ward. But if you don't give them a shot in the first hour, you might have one patient less. And that is not the intention of an emergency ward. Thus, if we do not act, we lose patients. We need to introduce ourselves at all organizations where they're working. There is nothing wrong with the work that the Dutch NPCF does, the Dutch Patient Umbrella. They do a lot of good work. They do a lot of good work for 17 million people. But they have, unfortunately, no time, nor knowledge, nor money to pay for rare diseases. And it's a shame that we do not take rare diseases in our plannings. Many countries do not have rare diseases in their electronic health record or whatsoever. And I think we could improve that by working together pan-European. And what the crucial thing is, that we need to work together, doctors and patients all together, because doctors have just as many problems as these patients. It were initially the doctors that begged for help. Our objectives are very clear. We want to ensure better diagnosis. Unfortunately, on the records we have now, Mr. Average or Mrs. Average, which has adrenal diseases, especially when it gets slowly, they suffer 8 to 12 years before the right diagnosis is there. We need to have better care in emergency cases. In the old days, doctors thought that the injection of hydrocortisone was only their job. Today, we are educating the patient that he or she will inject himself at any time when he thinks it's an emergency. And the third is, we want to have better quality of care. With all respect, in the Netherlands, we see that there is a scattered care for adrenal patients, and we're working on this moment on a care standard which is accepted by all relevant hospitals. We foresee, though, that not all hospitals will accept care standards for endocrine patients, and I think that is logic. For care disease, we don't have the normal procedure. For rare diseases, we need to work together. Healthcare works with square wheels, and they're proud of it. We need to work on round wheels, ladies and gentlemen, and we need to work together, and it's a shame that we still accept this. AdrenalNet wants to provide reliable information for doctors, for nurses, for patients. And we see they are all seeking for the same problem. Therefore, our website has been a success, tremendous website. And what we see also is we want to give answers on general questions because we want to reduce the pressure on the hospitals. If you have an adrenal patient which is managing quite well, he or she can go to hospital, let's say 1 time per year, providing he or she will have good contact with his physician over the internet by questions. So we need to facilitate a safe question and answer system. And what is also very relevant is that we get this co-management going. The idea that people still think that a doctor or patient can manage this on himself, he must live in a different time and age than I do. Because how can a doctor have so much experience about being ill? The doctor has a lot of experience of the disease as itself, which the patients frequently lack. And AdrenalNet is a very good partner and component for the healthcare providers because in rare diseases you have little publications, we need to share them and we need to help the doctors. What you see with the present prices of publications, frequently doctors cannot have access to very relevant publications. So what we do is we buy them and we share them. And on our platform we share also experience from other healthcare workers. Because sharing is the new world. Having knowledge in your position, like old boys like me, are a danger for healthcare. Sharing is the only future we need to do. So if we don't share, there is no future for me, nor for many healthcare workers. And the participants in AdrenalNet ensure that we are only talking about the highest quality of care and only about the highest quality of information. All the information on www.bijnianet, or in the English edition www.adrenals with an s.eu, is controlled and checked by many doctors, nurses and patients. So what we need to facilitate is to work together. We need to facilitate close cooperation. We need to facilitate standardization. And we need to do a lot of advisory work to the insurance companies. And it's very, very, very shameful that insurance companies these days have too many people who have no knowledge about rare diseases. It is a shame that people are being checked by people who have no knowledge about rare diseases. And if you know that in the Netherlands we have maybe 20, 25 real doctors, specialists who know about these type of real adrenal diseases, you can see that it's very complex to get this communication going with the insurance companies. And we are actively working on that with an academic school. And we also want to reduce the regular visits to the doctor, to the hospital. Because, ladies and gentlemen, what's the use of going 4, 5, 6 times to the hospital and hear that your weight is improved or gained or that your blood pressure is go? It's totally, absolutely useless. Because waiting lists are increasing. And if you have today a serious problem, you need to see a doctor tomorrow. So those who are not needed to go to hospital should stay at home. But we need tools for that. Just for you to what has been done and what has been achieved in the last 14 months. We went to the ambulance brothers. What a complete situation is there. 26 different districts in the Netherlands. So I had at least 52 cups of coffee before we got this. But we have a national standard for ambulance brothers and adrenal diseases. We have the European emergency card, 15 languages, 45,000 cards being distributed over total Europe in 15 different languages. We have the crisis kit, specially made for the patients, everything on board. If you are in bad shape, inject yourself, talk later. We have the seatbelt card holder, agreed with the ambulance people. If you see this, first inject him, then talk. We have this made seatbelt card holder available to the rest of Europe. We have sold 12,000 to the rest of Europe. So don't tell me that there is no demand. The demand is bigger than we can solve on this moment. We have made animations to educate patients, to educate nurses, to educate carers. We thought the Dutch language would be good. We are now in German, we're starting in French. We have translated, thanks to Professor Oleg Medvedev, in Russian. In Turkish, we have the animations in Arab. Because the German doctor said we have a tsunami of Turkish patients and we cannot manage, we cannot communicate. Well, we have made the animations and the Germans are now translating it and they generate the money for it. So, what are the present and next steps? We need to develop more languages, better cooperation, and there I'm very happy with TIC Salute, because in Spain the organization of doctors and patients is, let's phrase it this way, slightly different than in the Netherlands, and we need some support from TIC Salute. But we're also working on an international app, because in a world of today where patients are moving towards completely different countries and don't speak the language, have no idea about habits, do not vaccinate themselves in time, do not have enough documentation on them, patients should be made more individual. Today's achievements in the app. We have the prototype ready. Sorry, HIMSS is just 1 month too early, but otherwise we could show it. We have the agreement with the Dutch endocrinologist. What should we do in case of? And what is the SOS ambulance? It is translated in 6 languages on this moment. On the app are 3 animations to show what to do in what cases. So it's on hand, 100-second instruction. It is direct connect to the reliable websites, 2 buttons at the bottom. It gets, and that's really new, ladies and gentlemen, the blue button. Those who know what the blue button is, this will be the first app that will have the blue button on board. Epic will facilitate us together with Radboud Hospital next month to have the blue button information on the app. We will have an add-on on the adrenal information, so we have 2 buttons. And we are negotiating with the other main provider in the Netherlands called Chipsoft to do it in the other 4 academic centers. And that is very new. We have done yesterday the test to get connect with VZVZ, that's the LSP, the National Index Server of Medication. So if it works, we are in August in business, so you will have on your app your latest delivered medication. Ladies and gentlemen, there's a lot to tell you, and I can work with you for day and night. The only thing we need, partners and friends. If you want to be partner or a friend, come to me and we will work together in any language. Please contact me and we'll more than be happy to work together with you. Thank you very much.
Thank you. Is there any specific questions for Johan at the moment? I would just like to ask, is there anybody in here who actually uses a PHR as either a citizen, patient, or as a doctor? We have one there. And is it like a specific, like in the example of just a general one? Yeah. And do you benefit from it? Not yet. And why not? Sorry, I can't hear. Not enough? Content. Aha.
Yeah, that's, if I may answer on that. In the general apps, there is not enough content, and unfortunately they are very frequently not standardized, and they are not ready to exchange information in 2 ways. What we have done in this way, and that's of course thanks to my position, which was in the old days, I'm an old man, so I have a lot of experience. We went to all the boys and girls that make standards, and our app fully accepts all standards. It's SNOMED ready, it's ICD-10 ready, it's ICPC ready. It will accept all standardization activity that NICTIS will do, because there's only one way in healthcare. If you want to stay in healthcare, share, 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 share. Otherwise, please follow my question, go home.
Okay, thank you. I would just like to ask, because you've been really like more on a national or a regional level of approaching the PHR challenge. What makes it work? Because Johan's been saying he's been quite critical about the Dutch situation, and there's a lot of investment in it. What is going to make it work in Spain and in Finland?
I can say in Finland that far more, most usable, I think it's
Oh,
working
yes,
now.
Rina.
The best application we have is a possibility to see own medication. I mean own prescription, electronic prescription, and also asking renewal of prescription. That kind of service has really blown up the usage of the system.
Yeah.
So it's a concrete, useful thing that you can do.
So that's like very practical for professionals and patients to
Yeah.
gather information about prescriptions and medicine use. Okay. And what about you, Henrik?
I can say which is the most used part of the personal the electronic health record, but I guess that this the e-prescription is
Yeah,
one of
okay.
them for
Okay.
sure.
Yeah, okay.
Well, that is then exactly what we can deliver. We cannot deliver the prescription. We can deliver what has been delivered. Because if you have made an agreement with your pharmacy, it goes into the national index server, LSP in the Netherlands. So we will know, as from September on our app, which medicine you have been collecting from the pharmacy.
So I'd like to ask one last question before we end this session to the audience. Who believes, like in Holland or in whichever country you're from, like a national or regional PHR would actually contribute most for healthcare professionals and patients? Or do you think like an approach for specific patient-focused or disease-focused PHR will benefit more? Who thinks like a regional or national approach will gain most? Okay, and who thinks like a very specific disease-based PHR will gain most? Only one, two. Oh, that's more over there. And a lot of you have no opinion apparently, so then maybe you think both is best or not.
Yes, I think both are best.
Okay,
Both are best.
good. Yeah.
That's the only answer. Because we do not want to exclude anyone, and we do not want to put shame on anyone. We only want to share.
Okay, so sharing, let's go. Okay, thank you very much. Just, I had to tell you as a last thing, apparently in the eHealth Week app, you've probably all downloaded, you have to give your review about this session. If you like to do that, then thank you. Okay, have a good day today and tomorrow, and thank you for coming.
You're welcome.